Good morning, guys. Good morning, everyone. I have the pleasure of introducing my friend and colleague, Dr. Ali Zaidi, who's the director of our adult congenital adult congenital program here at Mount Sinai. In about 3 minutes or so, I want to give you some background on his extensive experience. He completed his medical school at Icahn University in Karachi, Pakistan. Subsequently, completed combined internship and residency in internal medicine, pediatrics, and Penn State. He was a chief resident there following his residency. He completed a combined fellowship in pediatric cardiology and adult cardiovascular disease at Nationwide Children's Hospital in Ohio, which is one of a leading program in congenital cardiac disease. He subsequently completed additional specialized training in adult congenital heart disease and pulmonary hypertension. Most of us are board in maybe one or two specialties. Ali has 6 board certifications. He's board in pediatrics, in pediatric cardiology, in internal medicine, adult cardiovascular disease, adult congenital heart disease, and adult echo. He, after completing his training at Nationwide, he was the director of research there, and in January of 2014, moved to Montefiore Medical Center, where he was the director of their adult congenital program. I was thrilled when we were able to recruit him to Mount Sinai, where he started here in January of this year. The Adult Congenital Heart Association is the body that accredits programs in adult congenital heart disease. There are 33 programs in the US. There is only one right now in New York, which is at NYU. Ali started in January. Within about 8 months, we've submitted an application for the accreditation of the program, and it's certainly all thanks to his incredible lightning speed and effort. We're very optimistic that with the support of our adult cardiac surgery program, Dr. Adams, our adult cardiology program, and Dr. Fuster, we will be able to receive that accreditation. Ali will give you some background on where congenital heart disease stands today, and please welcome him to our review.
Thanks so much. Good morning, everybody. Thank you for having me, Peter and Dr. Adams, Ani. Thank you for having me. I think I managed to. Can you still hear me? Yeah. So Peter's right. So I'm an adult congenital doc. I just took a long way to get there, which is probably not very smart, but it took me a while. My dad's a surgeon, by the way, and he keeps telling me that I did 10 years of post-grad training, and I'm not a surgeon, so I've done something wrong somewhere along the lines. But here I am. So what I thought I'd do here is I'd really give you a flavor of adult congenital heart disease sort of over the years and where it stands today, at least here in the United States and in Europe, and then sort of take you through a journey through the ages. And this is a little bit of a historical initial, maybe 10 or 15 minutes, and then I'll give you some data. So no disclosures. This is really what we're going to do. We'll talk a little bit about the history of congenital heart disease. It's a little nerve-wracking standing in front of surgeons and cardiothoracic surgeons and giving you a history of congenital heart disease surgery, because really that's what it is. That's really how the field grew. I'll talk a little bit about transition, and then heart failure transplantation, which is really sort of raising its head in adult congenital heart disease, and then really what lies ahead. So here we'll start with the beginnings of congenital heart disease, and I always show these initial slides saying, well, when did congenital heart disease start? So when did we? So I always say, well, it's congenital, right? So it probably started pretty early on. The first day of life is sort of where it started. But when did we start hearing about it? So Da Vinci, not that he had it, and not that. Hopefully this will play. Oops. Jump. Well, I was going to say with Da Vinci, and I don't think this is playing on this, is that Da Vinci actually drew the heart, and he actually drew the fetus. And what he did was he drew anomalous coronaries in his paintings, which I thought was fascinating. In the 1700s, he was drawing anomalous coronaries again back several hundred years ago. But really, where congenital heart disease was first sort of made its landmark, I think this is stuck here, was Neil Stenson. And now you might know Neil Stenson. I apologize. This is not actually showing all the pictures, but was in 1671. And what Neil Stenson did was that he described really what was tetralogy of Fallot. But Neil Stenson is not known for tetralogy of Fallot. He's not known for that. What's he known for is the Stenson's parotid duct. That's what he's known for. But he's the first one who described a VSD, RV alpha tract obstruction, an RVH, and a misaligned aorta. But he never got his name associated with it. This is 1600s. So I was talking about Matthew Billy, and so he drew the transposition heart in 1700s. But I'll bring you to England. And that's Charles Dickens. And why is Charles Dickens associated with congenital heart disease is because the fascinating story behind him is that the first children's hospitals that started coming into play, the big children's hospitals, really the three, the Great Ormond Street in London, Children's Hospital in Philly, and then Boston Children's Hospitals were right around the 1800s. And Charles Dickens was actually one of the names behind Great Ormond Street. He was really a financier to Great Ormond Street, which is really what became the home for congenital heart disease in Europe. But in the late 1800s, you've heard of him, Arthur Fallot, and he's the first person who described the four features of tetralogy of Fallot. But remember, Stenson did it 100 years ago, but never got his name associated to it. But Fallot did, and that's what stuck, was tetralogy of Fallot in France. That's where he got his name. And then William Osler, in sort of the late 1800s, early 1900s, in his book, The Practice of Medicine, which is really considered the gospel for medicine, what did he write in 1897? And there's a section on circulatory diseases and a 5-page chapter for the congenital afflictions of the human heart by William Osler. 5 pages. That's what was written for congenital heart disease. And then this is in the late 1800s, early 1900s, here in New York at New York Presbyterian, just down the road, the Children's Hospital. And this was Emmett Holt, who was a sort of a big name in pediatrics. And what he did was he talked about the congenital anomalies of the heart, and you can see there. And this was in essence a 7-page chapter for the congenital anomalies. So again, late 1800s, early 1900s, people are talking about it, they're writing about it. There is congenital heart disease on the horizon. But here's Theodore Billroth, and I like this because he's you know what Bill Roth is, a general surgeon, and this is what he said in the early 1900s. A surgeon who tries to suture a heart wound deserves to lose the esteem of his colleagues. This is like performing an operation to the heart. It's a tantamount to the act of surgical frivolity. This is Theodore Billroth, which I thought was very interesting. And I said, my dad's a surgeon. I ran this by him, and he's like, I don't believe this couldn't happen. I said, no, he said this back in the day. So again, congenital heart disease, congenital heart surgery was being talked about. But late 1800s, it is an ailment that is described, but is described as not compatible with life. It's not compatible with life. If you have congenital heart disease, the chances are you're going to die. Canada, early 1900s, and this was fascinating because the origins of congenital heart disease in the 1900s really came from women in cardiology, and that I think is again historical in some ways because she was in Montreal and she wrote in 1936 an atlas for congenital heart disease. Again, there's no surgery at this point in time. There's no echo. There's no MRI. She wrote, and in essence, she was writing on pathological specimens. But what happened was that when she wrote this book at Montreal, she was told that she can't practice as a cardiologist, and she was asked to actually be in the pathology lab. She retired that year. She called quits, she retired, and then she died a few years later. James Brown in London, 1939. And this, I think, was fascinating. And what he wrote in this book was that people with children with congenital heart disease remain sheltered in their homes. They're incapable of sustained activity. They're so incapacitated that some have not even walked. They're underdeveloped. Some are retarded mentally. They don't have the education. He's describing congenital heart disease patients in 1939 in London. But what I thought was really fascinating, this is at the bottom, and those of us who do adult congenital heart disease now, is that the subjects of great affection, they're still the subjects of great affection from their parents. They can't do everything, but they're... And what happens is it is peculiar to note that both parents still accompany the child. to the clinic with. And those of us who do adult congenital heart disease, we still see this to this day. Mom and dad are coming to clinic. And I think it's interesting because they were writing about this back in the 30s. But when did surgery start? And this is where the paradigm shifted. This is where congenital cardiac surgery comes to the forefront, and this is where it changed. So what are the beginnings? And I think this is the first surgery for congenital heart disease that made its mark, the PDA ligation. This is done in Boston in 1938, and this is Robert Gross at Boston Children's. He did it. He was the first person who did it. He did a PDA ligation. And what's a fascinating story about this gentleman is that's the child. He did the surgery, and she went on to live till she was in her 80s. But what's fascinating about this story is that Robert Gross was actually the resident. He was not the attending of record. The attending of record was Bill Ladd, the Ladd operation. And Bill Ladd was actually not in the hospital that day. So Robert Gross actually did this without Bill Ladd being there. I'm not advocating this for anybody, those of you sitting at the back or residents. He did it without Bill Ladd knowing. Robert Gross got fired for 3 months and he was brought back on faculty once they said, well, this might change the flavor of where we're going to go with congenital heart surgery. The same year, it happened in Dusseldorf, Germany. Dusseldorf PDA ligation was done. But Robert Gross's name is associated with it because this gentleman who did it actually did the surgery, but his records got burnt in a fire. So it never actually made it out that he'd actually done it. Sweden, coarctation of the aorta outside the heart. This is a landmark surgery. Clarence Crawford did this. He did the surgery. He did basically what was at that stage was considered a subclavian turndown, and he did a coarctation of the coarctation repair. But the landmark surgery that got the flavor going for congenital heart disease was in November 1944, was tetralogy of Fallot surgery. And this is a fascinating story that most of you must have heard about. This is Alfred Blaylock. This is Helen Taussig, and this is Vivian Thomas. This is Johns Hopkins in Baltimore. And this was a fascinating story because Vivian Thomas was actually taking care of these blue babies. She was a pediatric cardiologist in the 1940s in Baltimore. And she knew there was something wrong, and she was like, well, we got to do something. Blaylock was at Vanderbilt, and he moved to Johns Hopkins. And Vivian Thomas was actually a carpenter who was working in Blaylock's lab. And he was sort of designing pulmonary mechanics to pulmonary blood flow at that point in time. But this is what they said. They said, well, you have tetralogy of Fallot. You can't get blood up into the pulmonary arteries. Here's the VSD. There's RV alpha tract obstruction. Can't get blood out. We're going to do a shunt. We're going to bring the subclavian artery down into the left pulmonary artery. We're going to do BT shunt. And that's what they did. But this is the cartoon that was done. This was the child. This is a fascinating OR picture. This is Blaylock that's operating, and this is Vivian Thomas, who's standing right behind him, not operating, but actually guiding him to do the surgery at that point in time. So Vivian Thomas was actually in the OR at that point in time, helping Blaylock do that first BT shunt. And what was really fascinating also was Blaylock at that time had trouble getting anesthesia for this operation, and he actually went to Austin Lamont, who was the chief of anesthesia at Hopkins, and he basically said, "I'm not doing it. I'm not putting that child to death. Not going to do it." So he then went and he actually got Merrill Harmel, who was a junior faculty member, to help him do the anesthesia at that point in time, and this became the BT shunt, and that was 1944. What was really fascinating was this OR report. I got this from the journals, and it took me a little while to scan it in and get into it. This is what Blaylock said in his OR report. The patient stood the procedure better than I thought. Better than I thought. It is interesting that cyanosis did not appear to increase very greatly. However, the child survived. So he was going in thinking, well, we're going to take a shot at this. Probably child may not survive. And that's the hand-drawn drawing from Blaylock himself, the BT shunt that he did the takedown, brought the shunt down to PAs. But in the 40s, what this procedure did for congenital heart disease was the Twitter of today. This is what it did. It made the headlines. It made the headlines in the 1940s saying the blue babies are going to be saved, and this became a major landmark surgery at that point in time. But what people don't know is that first child actually died within 5 months. They died within 5 months, but they kept doing the BT shunt because this was the first time that these blue babies were saved. And over the next 5 years, many BT shunts were done. And only about 40% of them were surviving. But the question still remained, can you get into the heart? Can you get into the heart? And again, to cardiothoracic surgeons, I mean, this is in the 1940s, 1950s, and was the concept of the heart-lung machine. was a heart-lung machine that came in the 1950s. This is John and Mary Gibbon. But what's fascinating about the heart-lung machine and John Gibbon was that when he did his first surgery, it was it was a congenital case. His first case on the heart-lung machine was an ASD closure that he did, and this was done in 1953. And this patient actually did fine, but his next 5 patients died. And at that stage, John Gibbon was like, "This is not the step in the right direction. Let's not do this." Which then brings me to Minnesota, and this is Walton Lillehei, a landmark cardiothoracic surgeon in Minnesota, who then said, "Well, if we can do this, and we have done this before, we're going to do this in a congenital heart patient." This was a fascinating, again, a landmark case. This is a little bit of an older kid with tetralogy of Fallot. Walton Lillehei, Dr. Warden, and Dr. Cohen at that stage got together and said, "We're going to do open heart surgery. We're going to go in and we're going to fix this." And they said, "That's fine." This is the OR picture, and I think this is fascinating. Fascinating picture. This is them operating. This is them operating. But what you'll also see is a second table. You'll see a second table that's going on at the same point in time. And this is, so what did they do was cross circulation in the OR doing this, which is patient, pump, dad. And that's what they did in the 1950s. This was fascinating because when you actually look at the OR record, this is all that he did. He actually went to this chief officer at in Minnesota, and he said this is what he wanted to do, and he quoted a 200% mortality risk. When you look at the, think about that for a second, 200% mortality risk, and that's what he did. And this is what and they said, by all means, Walt, go ahead. This is in 1954, and I thought this was fascinating because this kid survived. But that was sort of the first open heart complete repair for tetralogy of Fallot that was done by Walton Lillehei. Late 50s, this is Dr. Senning with switch. So this is with an atrial switch. This is transposition, RV to the aorta, LV to the pulmonary artery, and this became a landmark surgery, where what they did was an atrial baffle. This was modified by Dr. Mustard in Toronto. And what that really means is you're doing an atrial baffle in the 1950s and 1960s. So these kids were then surviving with transposition. And then brings me to 1960s, where this was the first time that interventional cath sort of raises its head. Thus far, it's all surgery. So where was cath at this point in time? And this was Bill Rashkin at CHOP, where he basically said we can palliate these kids. We can palliate these infants, because at that point in time, the surgeries that were being done were still being done a little bit of an older kid, so not the really true infants or the neonates. And what Bill Rashkin said was, we'll put a catheter into the heart and we'll create an atrial septal defib. We yank. And those, if you ever go to a pediatric cath lab and see this procedure, it's one of the most jaw-dropping procedures, because the catheter goes up, there's a big balloon, the baby's about this big, and they actually yank. They yank that catheter, the whole baby shakes. So you got to keep the baby down, because they create that ASD to create that sort of shunting in the heart. And this is what Bill Rashkin did in 1966, first interventional cath procedure. And since then, there were PDA ligations and devices and so on and so forth. I'm going to bring you to the Fontan in the mid-1970s, single ventricle physiology, thus far not palliated. And Fontan basically said, well, this is tricuspid atresia. This is blue blood coming from the IVC. You can't get into the RV. So what he said was, IVC coming up, we're going to take this to the left pulmonary artery. So there's a valve conduit here, IVC, atrium hooked up to the left pulmonary artery, SVC comes down, disconnected to the right pulmonary artery, blue blood goes to the lungs, comes back to the single ventricle, goes out into the aorta. First time the Fontan palliation was done, and this has sort of, in essence, has changed, modified over the years, but the Fontan procedure is still the go-to procedure when it comes to single ventricles. 1970s, now we're in the 1970s. This is in Brazil. Back to transposition. This is Zaidi, who was a cardiothoracic surgeon. What he did was, let's not do an atrial baffle, but we'll do an arterial switch. We'll translocate, we'll move the great vessels, we'll translocate coronaries, we'll do the Zaidi arterial switch, and this is now the go-to surgery for transposition. Why am I bringing Dr. Zaidi up? Is because once he was all said and done, he actually quit cardiothoracic surgery, became the health minister for Brazil, and that's how he retired. Came up with this landmark surgery, but he went into politics at that point in time. I'm going to bring you to the late 70s and bring you to prostaglandins. Thus far, these kids are still getting surgery. They're still getting palliated with cath labs. Prostaglandins comes into the market. And this is what sort of changes the flavor, because now you can keep shunts open, PDAs open. And then in the early 80s is hypoplastic left heart syndrome, which for those of us who do congenital heart disease is sort of a life-threatening condition. And Bill Norwood comes up with his procedure. It's a Damas, it's a neo aorta that's in essence being created. There's a modified BT shunt, and this was in the early 80s. So now we're in the 80s. Now we're in the 80s where we're doing this sort of procedures. But I'm going to jump about 15, 20 years, come to this, which is the Melody valve. And the Melody valve was the first time a transcatheter valve was deployed successfully in an adult patient. And this was done in London, initially developed in Paris and then done, and really done and sort of taken forward in England. And this was sort of the first time a transcatheter valve was done. And since then, obviously, the valves have taken off. Which then brings me now, so we're now in sort of the birth of ACHD. So the question then comes to our mind is that what I've just taken you through is over the last 60 years or so, where congenital heart disease has gone from, in essence, being an ailment that's not compatible to life, now doing open heart procedures. Well, what about adult congenital? When does that come in? And in the mid-1970s, again at the Brompton in London, Lady Jane Somerville writes about adult congenital heart disease, and she calls it grown-up congenital heart disease, Gooch. And that's in 1975, and she wrote this paper, which is actually fascinating. It's in the Lancet, and she says this is going to be the tsunami that's going to come and hit in about 20 years. In 1975, this is what she said. And this then moved to Joe Perloff in late 1970s in UCLA, the first adult congenital clinic in the United States at UCLA in 1977. So again, still pretty early on, but that's when they were leaders in the field that were thinking about adult congenital heart disease. So what about outcomes? I'm going to shift gears a little bit because the story really starts with the last 60 years. Well, where were we 60 years ago? Where are we now? And this is what it is. It is the most common congenital defect, not congenital heart defect for children. The most common congenital defect for children. So if you take everything else, cystic fibrosis, you take sickle cell, cancers, congenital heart disease is the most common. The initial goals were get them to 1 year of life, get them to adolescence. And what we know now is that they're survived, and they're survived to adulthood. And the data is fascinating because in the 1960s and to, let's say, in the mid-2000s, this blue circle is kids with congenital heart disease. This red circle is adults with congenital heart disease. In the 60s, more kids. 80s, equivalent. 2000s, there are more adults with congenital heart disease than children with congenital heart disease. This is national data. This is data that's from the United States, and I'll show you some data here in a second too. What we're seeing is that over the last 50 years, the survival per decade has improved by 10 or 15%, where we now know that it's over 95%. It's even more than 90%. It's more about 95% that these kids survive. So these are kids surviving with congenital heart disease. Well, what does that mean? Is that we get them to adulthood. We get them to adulthood. So this is data from Toronto, and I'm just showing you complex congenital heart disease, triatresia, transposition, coarctation. And what does this mean? What this means is, yes, they survive, but this is age of death. They do die. There is mortality. And then what that means is that they die from sudden death, they die from heart failure, and they die from other complications, including the strokes. But the average age of death is somewhere in the late 30s. This is data from Canada that, yes, we get them, but they're dying from heart failure and they're dying from arrhythmias. This is data from Europe, and just breaking this up, not to belabor this, but when they survive, they're surviving with a burden, and the burden is arrhythmias and heart failure. And I'll drive heart failure home in a couple more slides here in a second, because roughly 25 to 30% of these young adults will have these complications. It's, again, the mean age is about 30. That's when the problems start to arise. So what does this mean in the United States? What this means in the United States is we have more adults than children. We have more moderate and complex congenital heart disease, and now we have 2 million adults with congenital heart disease in the United States. This is national data. They're out there. These kids are surviving. They're now adults. We know this. So what does this mean? What this means is that this is what these kids are these young adults are dealing with, a lot of complications. So those of us who do adult congenital heart disease, I'll wear my medical hat on, and this is what we see. We see the arrhythmias, we see heart failure, we see pulmonary hypertension. These are young patients in their 30s, 40s, maybe in their 20s that are dealing with this. The only reason I'm showing you this is because I'm going to come back to this slide in a second. But the question I want to ask is, well, where are these patients now? There are 2 million patients in the United States. We're in New York City. Where are these patients? Well, this is what happens. They get lost to transition. What happens is these kids are fine when they're in their 12, 15, 16, 18-year-old cohort. They're doing okay. They're running around. Peter and Raghav have done great surgeries, they're doing well, and they're fine, fine, fine. But then in their 20s and 30s, they start getting sick. And this is what happens. This is national data. They show up in their GP's office. They show up in just a general cardiologist's office, which is completely fine. They show up in orthopedics office, in a dermatology office. They show up in ERs or ICUs because they're not transitioned. They get lost to care, and this is what happens. And this is, again, data that's out there that shows that these patients are getting lost. This is a fascinating slide, and I'll just show you that this is the number of patients that are being reported in the United States. Now we think it's 2 million. This is about 5 years ago. We thought it was 1.3. But only 42,000 patients in the United States have ever touched a adult congenital heart physician so most of these patients are still lost to care. They're lost to care. And this is just fascinating data because the question then is, well, what happens to transition? Well, why aren't we know these kids are being seen, right? They get the operations. They're being seen in children's hospitals across the country. Well, where do they go then? What happens? And this is the issue with transition is that we are now, so I'm going to wear my pediatric hat on for just a second. I'll bring it back to internal medicine, is that transition means you're going to move from family-centered care. So mom and dad, if a child is sick, be it congenital heart disease, they're going to go to the pediatrician, they're going to go to the pediatric cardiologist, they're going to be seen in a children's hospital, and then the child grows. Now you're 18, 21, 22, and that transition never happens. They get lost because now you're moving from family-centered care to specific individual-centered care. Now the onus is on the patient. Now the onus is for that young patient to sort of take care of his or her own health, and that doesn't happen effectively in a lot of centers, not just in New York, but across the country. This is national data. We lose them. There is morbidity. There is mortality. And this is single center from Toronto, again, just showing you one center, one clinic. This is starting when they were 6 years old, 100% follow-up. They go to 22, only 39% being followed. Same center, same hospital. You have a pediatric children's hospital, you have an adult hospital, and only 39% of patients were followed. And it's because these patients feel good, they're feeling fine, and then they sort of get lost. And this is something we see all the time. This is a patient I saw when I was at Nationwide at Ohio State when I was a fellow. This is a 32-year-old Fontan, lost to follow-up, shows up in the children's ER. With shortness of breath. This is a single ventricle, and this is a big thrombus that was sitting in the Fontan circuit. And clearly, this patient was in trouble. Had edema, Zaidi, was lost to follow-up. Eventually, got a heart transplant. Again, and this is something that we see. So the problem is this. This is a national phenomenon. This is not something that's unique. This is a national phenomenon that there's a bridge. There's a pediatric system, there's an adult system, and we got to cross that bridge. There's a national data that I'm showing you. So the question is, and I'll show you this in a second, is like how do we get around this? Well, we now know that adult congenital heart disease is not a pediatric illness. It is not a pediatric illness. It is an adult illness. It is an adult congenital problem. It's something that we live with in the adult medicine world and in the adult cardiothoracic world. So here's a fork in the road, and only bringing the fork in the road, I won't get into this for today's talk, is pregnancy. These women now get pregnant. Not only are they surviving, they get pregnant. They want families. They want children. They want to get through this. And again, not to belabor this, but when we get into pregnancy, there are lots of different things we look at, and this becomes a multidisciplinary approach. And again, not for today's talk, but what I'm going to bring you to is what lies ahead. I'm going to spend the next 10 minutes, or maybe 7 minutes or so, talking about what lies ahead. And this is that tsunami that Jane Somerville talked about in London in 1975, that these patients will grow up. And they will get into their 20s and 30s and 40s and 50s, and this is us. And this is them. And we see this a lot, where these patients come in with heart failure and arrhythmias, and then they get very, very sick. They're very young. And Ani and I just we were taking care of someone recently who was a 45-year-old transposition, very sick gentleman. That's what happens. He got lost to follow-up, got very sick, and then eventually it was heart failure. So what does this mean? Well, this means is we innovate. We go forward with innovations. And what this means is that we are now moving towards repeat if we had to do repeat operations, what can we offer them? We offer them personalized devices. So now the cath world is coming to a stage where there's a new valve that's being developed, and there are lots of different percutaneous valves, but this is what's called the Harmony valve. And I know it's a funny name, is Harmony valve. What they're doing is that they're designing with stem cells, and there's a scaffold, and it goes through a catheter into the heart, and it's designed to every specific RV outflow tract in this room. So every one of us has a different RV outflow tract, and this is our right-sided valve, but this is being developed. So we actually, you get the model, you get the stem cells, you get it engineered, and it goes in, and it actually models to your systole and diastole because it becomes a part of your RV outflow tract. And this is now being deployed. Leadlet pacemakers, sub-Q ICDs, we know all this. 3D printing, it's raising its head, especially for congenital heart disease, and this is a patient where we were trying to figure out a VAD placement for a right ventricle, and then we did this model, and what we could do is we could take out the anterior wall of the right ventricle and go to the surgeon and show them and say, well, this is what the inside of the RV looks like. So when you do the cannulation, where will the cannula go? We can actually show where the moderator band, the muscle bundles will sit, so the surgeons know that going up front. So again, this is innovation. This is 4D flow. This is MRI, and this is pretty cool. This is a coarctation. You can actually see the turbulent red blood. It should all be blue and smooth sailing and laminar. This is a Fontan. This is SVC coming down, IVC coming up. It should all be nice. It should be nice and blue. So we can see turbulence now with 4D flow on MRI. So this is all that's on the horizon. I'm going to spend 5 minutes and talk about heart failure, mechanical support, and transplant, because this is raising its head in the world of adult congenital heart disease. You know this. See, this is 1960s. This is landmark surgery. This is not to do with adult congenital heart disease. But why am I showing you this? Is because I don't know if you know about this. In 1980, you probably do. Was Leonard Bailey? This is a fascinating story, and is that Leonard Bailey was at Loma Linda, and this was a hypoplastic left heart baby. And he actually did a cross-species transplant. Bragg probably knows about this. And he did transplant the heart of a baboon into the child. And this was done in 1984, and the child survived for 5 days, but then had a lot of immunological reactions. But that is the baby post-transplant. That's the baby post-transplant. This was in 1984, and never did again. But why heart failure? And why am I talking about heart failure again and again? Is because we're seeing this in my world now, where my adult cardiology, adult congenital heart disease on, is that these patients have heart failure. The problem is, how do we define heart failure for an adult congenital patient? Because you might be dealing with a transposition systemic right ventricle. You might be dealing with an arterial switch, a single ventricle. Might be dealing with somebody with shunts and things along those lines. And what's really interesting about heart failure is people have tried to define heart failure and congenital heart disease over the last 20 years. They've given multiple different definitions, and nothing really has stuck. Nothing really has stuck. So not to belabor that, but this is fascinating, and I'm going to take you the last 10 years, just last 10 years data that I'm going to show you, is that what they're saying, and what there's data that we know of, and that heart failure in adult congenital starts from birth. So in the sense that you're not just going to be in heart failure day one, but it flip-flops. If this is your symptom threshold for heart failure right here, these patients go up and down and up and down and up and down and up and down, and that's what these patients do from when they were kids. So we're not dealing with the 65, 70, 80-year-old with ischemic heart disease. We're dealing with the 5, 10, 15, 20, 30, 35-year-old with a systemic RV, for instance, and they fluctuate. They have surgeries, they have arrhythmias, they have reinterventions, they have decompensation, and there is an underlying risk of sudden death that remains in these patients. And this is sometimes difficult because the question then is, well, how do you manage them? What we know is that heart failure admissions have tripled in the last 10 years for adult congenital heart disease patients. They keep rising. More and more of them are showing up with heart failure. And again, going back to the data that I showed you, that these patients can die from either heart failure, arrhythmias, or sudden death. So what can we offer them? This is standard therapies. I'm wearing my adult cardiology hat on. Goal-directed therapies, CRT, inotropes. But really the question is, can we offer them mechanical support? Can we offer them transplant? What is the data that's out there? So this is roughly in the last decade. This is an adult with Epstein. I'm going to show you this case, just show you what the heart looks like. This was a 45-year-old that I took care of a couple of years ago, had Epstein's, had a tricuspid valve repair. She was a school principal doing fine out in the community, but she had ascites. And she was being paracentised every 3 months. She was seeing just a regular cardiologist out there. She was getting paracentised. And this is what a heart looks like. I'm going to let this play. This is an MRI. This is anterior. This is posterior, and this is when I saw her. This is just to show you what the heart looked like. This is the whole right heart. This whole thing. This is the little LV down here. This whole thing is still the heart. This is the whole thing is still heart. She was being paracentised because when they were scanning her, they couldn't get the entire heart. So they were only getting this sort of edge of the TR jet, and they said, oh, there's not enough TR. She's probably doesn't make sense. Must be something else. They couldn't get the whole heart in on the echo images. Eventually, she got a transplant, and she did fine. So, well, what are the guidelines for adult congenital, right? So, what are the guidelines out there? So, I've shown you sort of data. Well, what are the guidelines? This is in 2012, 7 years ago, first time that somebody from the AHA said we're going to write a statement for adult congenital heart disease. And this is, again, and I'll show you what it shows at the bottom is that here's what it says. Most patients with complex congenital heart disease are not candidates for MCS. A careful preoperative consideration should be done. Individual patient's anatomy may permit successful. I don't know what that means. I mean, no, I have no idea what that means. But this was the first time they made it out there. This is 2013, looking at the Journal of Heart-Lung Transplantation. They came out with guidelines. But what they commented on was the use of VADs. They said, what is the data for VADs in adult congenital heart disease? And I thought this was fascinating. So let me just show you this. So this at the bottom, if you look at the sort of the bars that have this sort of pattern on it, that's congenital heart disease at the bottom. The other is non-congenital heart disease. And over the last 10 years or so, look at the use of MCS in acquired heart disease versus in congenital heart disease. Flat. It's flat for the last 10 or 12 years, and that's really been the case. And again, the question is this an era effect or not? And these are actual numbers of outcomes with VADs at the time of transplant. With congenital heart disease, 20 were transplanted, 17 died, 5 removed, and look at with and without. These are, again, acquired heart disease, so the numbers are small. The numbers are small across the country, and there are reasons for this because the anatomy becomes a precluding factor. So we know this that VADs are there, but it's difficult to use them. So can we improve the utilization of VADs or mechanical circulatory support? Well, there's now data arising that maybe we need to use technology. We need to get to imaging. Do we need 3D printing? Can we get our surgeons to the working with the non-invasive docs and say, well, can we offer mechanical support? So another statement came out 3 years ago from the AHA, and this is what they said, that yes, you can use VADs with stage D heart failure. You can use it if there's adequate anatomic and physiological conditions. There's severe limitation of exercise. So again, a lot of broad strokes, nothing that was really hitting home, but that's where we were at. So in 2016 comes transplant, and this is a fascinating side. Again, I'm going to show you this. This is adult congenital heart disease. So this is, again, heart failure. You're going to up and down. You then get listed for transplant, but within listing for transplant, there is an attrition for adult congenital heart patients. While listed, they start dying. Why listed? This is national data. But for non-congenital heart disease, if this is your symptom threshold, there is a little bit of a flat line. They drop, they get transplanted, and then they sort of remain. There is attrition. I'm not saying that there isn't. But in adult congenital heart disease, they go up and down, and then they get listed, and then they die while they get listed. So what does this mean? What this means is if you look at the old classification listing 1A, 1B, 2, this is the red is transplant. This is adult congenital, non-adult congenital. And what this really says is that yes, patients are getting listed. So these are adult congenital patients that are being listed, but there is an attrition. We know there is an attrition. They die while they're being listed. They also clinically get worse because their wait is long. So about 25% of them die. They did this meta-analysis. They looked at the risk factors, and if you look at the hazard ratios, they started developing renal function. They were in ICUs for a long time. They were ventilated for a long time. They started having liver dysfunctions. Again, not substantially different from acquired heart disease, but 25% of adult congenital patients die while being listed. So what this then meant was somebody did a meta-analysis, and I thought this was fascinating. This is about just 2 years ago. They looked at all the data that's out there for heart failure transplant, 6,000 papers for adult congenital that are out there that are being reported. Only 13 hit the metrics for acquired heart failure transplant, in the sense that you're actually looking at the guidelines for acquired heart failure transplant, say, can you apply to congenital heart disease? Only 13 papers that actually followed any sort of programmatic approach. A lot of it was anecdotal, was we do this, our center does this. So, and the problem with this was that I think there is an era effect, and I'm going to finish here in 2 minutes, just trying to explain this, is that this is now mechanical support to transplant. So you get them to transplant, then what happens? Well, this is 30 days. So this is, the dark blue is congenital heart disease, this is non-congenital heart disease. And what they showed was so yes, they have a rougher course, 30 days. This is 1 year. But 10 years out, there's a higher 10-year survival for adults with congenital heart disease. So what does this mean? Does this mean that we are seeing now the patients who are getting transplanted who are 30, 40, 50 years ago, who were initially palliated surgically in the 60s and 70s? And we're really not seeing the patients who are being, so as the surgical procedures and the expertise has improved? Well, this was era data from Europe, and this is just showing you that 1988 to 2000, 2006 to 2012, they split it in two cohorts. And what they showed was that 1 year data is now getting better. It's getting better now than what it was 20 years ago. So the data that was out there that 1 year transplant outcomes are worse might have been an error effect. And what you're seeing now is that the new transplant data says, yes, they are sort of catching up. This is just showing you median survival. Congenital heart disease is 15 years. Ischemic cardiomyopathy is 9, 10. Non-ischemic is about 12. So if you get them through, they live longer with transplants. So this is, and I'm going to end with this this is 2 months old data. 2 months old data from David Morales in Cincinnati. And this is fascinating because they looked at the era effect. And they said that, well, in 2000 to 2008, 2009 to 2018, this is all ACHD transplants across the country. 1 year survival was 78%. If you go back 20 years, it's 86%. If you're transplanted in the last 10 years. So again, looks like there's an era effect that's happening. The 5-year survival is again better if you're in the last 8 or 9 years. So the survival rates are better. And then just this last slide showing you when you compare them to acquired heart disease. And that's really where the money is, that when you compare to acquired heart disease. So the similar survival at 1 year now, this is 2-year-old data, that if you compare adult congenitals to non-adult congenitals, their survival is roughly the same. And I think this is because now you're actually seeing the era effect coming in, which we didn't before. So are we seeing it? I'm going to just run through this, showing you that this is a Fontan with a failing liver. And I'm just showing you this because this is something that Ani and I've talked about before too, is that these patients are now running into dual organ transplants. This is a single ventricle Fontan with cirrhosis. And we actually ended up doing a dual organ transplant on her. So this was on block. We did a few before I came here. So this is something that's happening. So ACHD transplant is certainly a village. I'm going to finish here, and we're just going to show you this 2 slides. I know I got late. I'm not sure I understand. Oops. Sorry, that's my phone telling me they're not understand. Here's accreditation. This is what Peter started with. We cannot do adult congenital heart disease now by just putting a shingle up. That we just can't do it anymore. The guidelines are that you have to have a program that has accreditation, which basically means you're going to work together as a multidisciplinary force and really bring in the experts from both adult cardiology, pediatric cardiology, cardiothoracic surgery. And I do believe that adult congenital heart disease becomes that link. And that's really what it needs. We're in the process of accreditation at this point. So I want to thank a lot of you in the room who've helped me with this. I know Robin and Paul, Ani, Peter, Dr. Adams, this is going to eventually come to your desk too. But this is what's happening, is that we have to go through site visits now. That we have the surgeons, we have the ICUs, we have the mid-level support, and we got to give them outcomes that we can do this. And this is where we're at now. So this started in 2016. In Jan 2016, we're in the process of accreditation now, and that's where we're going. I'm going to end this here by saying that that's what I really took you through, sort of whirlwind journey. And this is where Joe Perloff said is congenital heart disease in adults is the future of congenital heart disease in children. And that's really what's happening, is that these kids are now in this world of adult cardiology and adult cardiothoracic surgery. So I'll stop here. So I apologize, I was delayed starting and I had some computer difficulties, but I'll end. I'll stop right here. Thanks, guys.